Do you remember them?
Not really.
Not really? One of them, you said that the illness is giving you the power for waking up every morning and see what you can do for your community.
All right, yes.
And this was heartbreaking me. I mean, it was so powerful. And I know that for you, the Chinese meridians are also very important, the meditation, the way you talk to yourself. And this is something that shocked me a lot, because it's a way that I think that we all have to do, and they all we have to go ahead during the day. It's talking us good, respecting us.
Sorry.
Well, anyway, I want to say that you have to be very proud. You're very powerful, because if you have this kind of illness, it's because you have a lot of power and you can go over the illness. So make a big community, talk all together, affront all the problems together, and we can go flying everywhere we want. Okay. So now I would like to open the question and answers, and I would like to ask Professor Haifa if you want to join us here and make an open discussion. Yes? So I would like to start with something that we have been talking a lot or many times with Judith. These are these taboo topics. The taboo topics like sex, like going out at night, and all this. So, Professor Haifa, can you, or Judith, you want to start with one of these topics?
Okay. Now. Okay, so one of my biggest problems that I have is menstruation, like the period. It's very painful, and I can wake up in a week. It's a lot of bleeding and pain. So my question is always the same: what can I do?
Well, this is a problem not specific for MPN. This is present in many young females, and I think you have to be treated like every other woman. Sorry, my sound is disappearing since last evening.
Keep it closer.
Yeah. Okay. Yeah, but you have to discuss this with your gynecologist without, sometimes if you're taking aspirin, the bleeding might be more. But you should be treated like everybody else. And I think yesterday we discussed what are the symptoms related to MPN or not MPN.
My question is because when I talk about with my gynecologist about MPN, she doesn't know about it. So it's about anticonceptives and all of that.
Yeah.
It's
you can. We discussed this with you. They asked me because, as a hematologist, I don't know all the preparations and hormones and how much there is. Estrogen is quite not the best. Contraception with estrogen is dangerous because of the risk of thrombosis. But I know that there are new progesterone stuff. And so the gynecologist writes me what she wants to give. Right.
I use one, yeah.
For example. And then
with me it was like that.
Yeah, and this is perfect.
And I use one and I'm okay.
Yeah. And then I say, okay, I have no problem, and then you get the treatment.
Another question I always have is MPN and alcohol, like going out and drinking, if you are on a treatment?
It depends. Interferon does have some liver adverse events, but it is always a question of how much you drink. So occasional drinking is no issue, even with ruxolitinib, which I can do.
Okay, thank you.
Grapefruit is not that good.
Yeah.
I don't have a specific question, but I think it's part of the responsibility of bringing a topic because yesterday you mentioned this new thing on the 50.
Yes.
So I think one of the biggest concerns that in the WhatsApp group we have very active conversation is the topic about progression. So when we are talking about symptoms, I think it's kind of tricky in the young adults because maybe we don't have a lot of the symptoms we will have in the future. So I think with this type of new ways of categorizing things, it can be a little bit unfair for all of us that maybe we fear way more about progression rather than the symptomatology we have right now. So I just wanted to bring it again because I think it's something that it's one of the topics that are more repeated in the
right. This is a very good question, but it is not for IS only. It is a general symptoms. You know, this is subjective. I might have more symptoms. I might have less symptoms. The Chinese recently published the symptoms in IS and compared them to symptoms of non-IS. I would say non-IS. Because we always get heavy discussions. What? With 40 I'm not IA anymore or what? Yeah. And indeed, you said it, the symptoms generally are less in younger patients. Sure, more energy and stuff. But, and I think your stories have shown this very, very clearly, the impact, particularly on the social life, the impact on the mental life, although the symptoms are much less, the impact is much, much higher than what you would expect from the symptoms alone. And this is exactly what we discussed yesterday. So, you know, it is not the point of how much fatigue or how much concentration problems I have. It is the issue, how much does this impact my personal, social, and mental life? Exactly, this is the point. And this was a very nice publication, very recent, showing the discrepancy between symptoms and the impact of symptoms on life.
Are you able to share that?
Hmm?
Can you share that?
Yeah, sure. I have the publication, I'll send it to Peter.
Thank you.
Because I just made a presentation in a German-speaking congress just 10 days ago about IS and their different needs, pregnancy and stuff like that, so I will share that with you. I wanted to share it, but you said no slides, okay. By the way, I just want to make, you said you are 42, or what is IA and what is, it is a random definition. A, adolescent means not yet adult, that's why adolescent, from 15 generally, and many of you said the magic 15. And then up from the age of 18, then you are a young adult, and the definition is just 39. But this doesn't mean anything because we know that some patients, some persons, get the JAK2 mutation, particularly the JAK2 mutation, even if they are an embryo. There are very nice data to that. That means you already carry this mutation, and particularly the JAK2 is a not very strong mutation. It cannot cause the disease alone. It always needs a second hit. So maybe you get the second hit, we don't know exactly what the second hit is, maybe when you are 50, but you were still carrying the JAK2 mutation since your birth. You said it, this is an example, and we know that usually an average of 8 years between the mutation and the diagnosis. So, you know, nobody really knows when the disease started. Nobody knows that. It is the time, you know, you take the time when the blood test was done.
Yeah.
But this doesn't mean anything. And the question is, if I am 39 years and 364 days, and tomorrow I will get 40, will my disease change? The answer is definitely no. And here is Peter as the best example. An ayah remains an ayah for the whole life. This is very interesting. We have a project translational because one of my patients, she's a medical student now, she finished, she was 19 when I made the diagnosis with her. And then her doctoral thesis, we made, you know, translational, meaning taking the blood and doing all the genes and how these genes are working in so-called ayahs and non-ayahs. And ayah, per definition, is the time of the diagnosis and not the time of
great.
now.
So I'm going to be young for life.
Right. So exactly, we divided the patients in 3 groups. where the diagnosis was made when the patients were 40 and above, then those where the diagnosis was made even 30 years ago, but they were now mid-60s or 70s, and the true ayahs, they are still below 40. And interestingly, at the end of the day, the ayahs, even if they are 70, they still have some things, they remain unchanged from the very young people. And we know that one major complication, you said this, is thrombosis. The younger the patient, the more likely, because you know the life expectancy is much longer, so we have to take much more care to prevent thrombotic events. The second thing you said is progression. Because of the very, very long life expectancy, thanks God, the risk of progression is higher. And that brings us, I think, to the second question. You know, guidelines. Guidelines are not rules, and we just discussed this today in the morning. They do not, you know, they divide patients to low risk and high risk, which is totally stupid, based on the risk of thrombosis. You know, 60, and then you are high risk. This is stupid. Yesterday I was 59 and 364 days, I was low risk, and tomorrow I'm 60. Is your risk changing? No, it is not. So, you know, these are still several decades old, these classifications. And the question is, it's quite stupid. Should I always wait until somebody progresses? Should I wait until a thrombosis happens and then try to treat? And officially, it is still like this, low risk, watch and wait generally. And then when you get a complication, then we treat. But the question is, it is more logical to prevent. And now I think a lot of things are happening in our community from the scientific point of view to try to change this idea, to try to prevent and not wait for complications. So if you are 65, you have no problems, you have no cardiovascular risk factors. We know that the risk for thrombosis is very, very low. So why should I give this patient treatment? Well, yeah.
Basically, for a physician today, it's completely different like it was 40 years ago. I mean, when most patients were older people, you know, I got known when I was 50 or something, and then you have to work with doctors to worry, how can I treat him so that he reaches the 80s? Today, with all the people what you have here, you know, they are 20 years old, so you have to find a medication
for 60 years,
for 60 years,
70,
which
yeah.
we don't have. So you know, how
We
do you
do.
do it?
Yeah,
Okay.
but yeah.
But you know, and coming back to my story, you know, when I had to get medication, when I knew that I had MPN, there was basically no medication available. You know, we had the old interferon, which was a disaster, and we had hydroxyurea. So what you do, you're trying much more time to stay on phlebotomies.
Right.
And I think, unfortunately, there's a trend, but the physicians, most of them are young physicians, they immediately start to give a medication. I think it's for me, I would have stayed all my life on phlebotomy if I could. I always wanted to have that because I don't have to take any chemistry. So
Yeah.
I know you come to a moment because of spleen and other problems where you have to take something.
Yeah, and when you progress, then it is
But
more difficult to bring it back.
But the earlier today we start with medication, the earlier we come to the end of the possibilities of medication. So
Yeah, but we have to always think, what do we want to achieve with the treatment and what is the right point? You are fully right. I still have patients, young patients, even with the 60, 65, if they don't have symptoms, no thrombosis, no cardiovascular risk, we discuss together, should we really treat you, particularly calreticulin patients. We know that these patients, in the American guidelines, it is not age anymore for ET, but it is the mutation. If you are calreticulin, you have no thrombosis, then I don't need to treat you, and that's what we are doing. So I think today we are learning more and more to put a lot of puzzle parts together individually and decide what is the best. And always guidelines are always just to guide, but they're not a law. And you have really, I love MPN. I know for patients it's not that good, but it is always a challenge when I sit with a patient, because and I tell every patient this, we have to see what is right for you and not just for the statistics. And it is always the trial and error. And you have, you know, stories, and all the stories, I think, one patient finds interferon great, for the other it's not the best treatment. Ruxolitinib is the best for one, for the other it's not that good, and so on. Hydrea, even Hydrea is okay for a small group of patients. So it is very, very individual. And I put mostly in my presentations many, many hats, because, you know, you cannot just, and your stories have shown it, and I think if we continue with the stories, it is so individual and so challenging.
Thank you very much. I think, what's her name? What's her name? Celeste. I think you had a question, yes?
Yes. I forgot to mention that when I was diagnosed, I was JAK2 triple negative. And then they tested once again, and they discovered I had a weird JAK2 mutation, which is called JAK2 E180, and they found a second mutation which is called TET2. So my question is, what are the possibilities, because I'm looking to get pregnant, what are the possibilities that my future kid will have these two mutations? And if there's any changes that I can do to prevent worse development on myself during pregnancy.
Yeah, this is good, because today we know, we discussed yesterday familial predisposition, and indeed we know that apart from the somatic classical JAK2 mutations, there is a group we call non-canonical JAK mutations. They are outside the classical mutations, and some of these are actually, inherited. And this is in separate families, and again, alone they cannot cause the disease. For you personally, if you are well controlled, we prefer always low molecular heparin. If any reason you are high risk, because abortions and stuff like that increases. And we try to give interferon if it is possible. And pregnancy is quite possible. It's very nice. We have many data in the meantime. The results, if the patient is well controlled, the mother and the baby, the results are comparable to the normal non-MPN pregnant baby. So pregnancy is definitely possible. I have one young lady, huh?
Don't look at me.
We are not worried about your pregnancy. No.
I have a permit.
I have one very young lady, triple negative MPN, severe thrombotic events in the spleen, big spleen, and she does not tolerate interferon. And then she wants to get pregnant. She is on anticoagulation. And the first time when she said she wanted to become pregnant, she's on Xacrit. This is something we don't like for a very long time, because it increases the bone marrow fibrosis. Nevertheless, then she told me she wanted to get pregnant. So I told her, okay, thank you that you told me. I will now quit the job. Because this is, Then we thought, how could we do this? Because she had severe depression under interferon. So I switched her to low molecular heparin. This was okay. And then I have to give her cytoreduction because, all the thrombotic events. And we started with interferon, very low dose, and very sporadic, every 2 days. So I just tried it was a real challenge for me too. And we had the first baby. The gynecologist didn't understand that I wanted to have an intensive care because they said this is a young lady, and I thought, nevertheless. And then after 1 year, she found it very funny and she wanted the second baby. And the baby is now, I think, 3 months, you know, and I always say, I said it, I think, yesterday, this is my baby too, you know. So even in such a very complicated situation, you can have successful pregnancies. And for men, it's much easier, sure.
Well, I don't know, it's a question on that. Men and other guys. Like, I was told that I shouldn't try and conceive.
Why?
Because I'm on interferon and hydroxycarbamide.
Hydroxycarbamide theoretically, but it is a theoretical.
Okay.
If you want to be 100% sure, you can go to a genetics, to have a counseling. But we know we had with this tyrosine kinase inhibitor like ROX, males at the beginning of the development, pregnancy and males and stuff and blah, blah, blah. But today we know that the risk is very, very minimal. And I always send the people again, if I'm not 100% sure, but interferon doesn't play any role because we do it with the mother. So, no.
Good to know.
So we will have next year many babies.
I think we get a new What about some more questions from your side, ladies? The lower part, I didn't say anything so far.
Well, I just want to make a comment with what you just said. It's very helpful. Like I've had actually, my mutation is CALR as well, and I've had 2 thrombotic events. My spleen is huge. My liver is really messed up, and every time I've asked the doctor for many years. I mean, I've been dealing with this for 15 years. Can I have kids in the future? Can you think about it? And everybody shuts me down. Like, no, it's too complicated. You're going to die, or the baby's gonna, get it the same way. So it's very nice to hear it from a doctor.
You need to have a good doctor with a good experience, and I know that you in Barcelona have good doctors. They, it is really hard work for us too. As I said, I always say, tell me so I can just quit the job, but no. It is possible, and this lady was really such a big spleen, really.
Yeah, so thank you for sharing that.
Any other question? No? Okay, then I would like to come back. You want to see? Sorry.
Actually, I don't know how to use the word to ask you, but I have been pregnant when I'm diagnosed with ET. So my boy now is 6 years old, and I want to ask if there is a way to know or discover if he has 2 or no, the JAK2 mutation.
Don't do it. Don't do it. I said it yesterday. 2% of the normal population, when the JAK2 mutation was first described, they wanted to see, as I said, it is not alone, never, it can never alone cause a disease. So they have examinations, 20,000 was soldiers in the United States, and 2% of healthy, perfectly healthy men and women, they had the JAK2 mutation. We know up from the age of 70 years, around 10% of the people have some of these mutations. And the most frequent mutation is JAK2 mutation. And still these people don't have MPN. So, and on the other side you have the triple negative. So, if you do know that you have a mutation, you will destroy your life mentally. You cannot change this. And you will not be able to do anything because this will be the devil. So I never advise doing a JAK2 mutational analysis unless there is a reason. Blood counts are not normal,
So I want to ask you, it's possible for him to have it, or
Yeah, familial predisposition, and sometimes this is possible, but you have said 14% in an analysis, but again, on the other side, 86% have no family history. So without reason, don't do this.
Thank you. Well, actually, coming
Maybe,
back.
sorry, I have one very important thing to say to everybody.